Everyone, thanks for joining us, and thanks for putting up with the kind of new process for enrolling yourself and joining the meeting. There seems to be a lot of new faces on the meeting, so nice to meet you all. My name's John Wilson. I'm an EMICM Reg in Glasgow, and I have been helping with some of the behind-the-scenes stuff with Samson for the last kind of couple of months. We're really pleased to introduce Michael Griksaitis. He's a consultant in paediatric intensive care down in Southampton, and is the kind of lead for the kind of CACTUS POCUS modules, which are essentially the equivalent of kind of Fusic, heart and lung and so on, but for paediatrics. So yeah, we're really pleased to have Michael joining us, and I'll hand over to you now to make a start.
Great, thanks very much for inviting me. It's always a delight to talk to new people about paediatric POCUS. I'm planning to do 2 sessions with you, or perhaps more if you want them. But the first session, which is today, I really want to use today to set the scene for you about what CACTUS is, and look at some of the differences and in fact the similarities between the adult pathways and the adult clinical POCUS findings against children, and hopefully start to give you an insight into the fact that it's not that dissimilar. And I would suspect most of you in the audience are from a critical care type specialty of some description, whether that's emergency medicine, ICM, anaesthesia, acute medicine, where you might very well be seeing children in ED at the request of your paediatric colleagues. And I'm hoping that by the end of this session, you feel empowered to take the skills that you have with adult echo and adult other POCUS and actually use it on children and find how helpful it can be. The way this talk's going to work is, I'll share my screen in a second, is we'll go through some sort of background stuff to CACTUS and how we've developed it and what's going on in paediatric POCUS, so you understand the background. Then we'll do a little bit of clinical stuff looking at what is different in paediatrics, because there's actually very little, but it's reassuring to know there's very little. And then at that point, I'm going to stop the recording, because I've got a couple of cases that I'm going to show you to just demonstrate how you can use it. And the reason I'm stopping the recording is we have got some patient pictures in there to help you apply this. I've got consent for these, but I haven't got consent for recording and sharing outside of a sort of a lecture style environment. And then we'll end it with some Q&As, but feel free to chip in as we go along. The second session that I'm planning is much more cardiac echo focused, which is I've got 10 neonates that have presented to ED over the last few years that have collapsed and are peri-arrest when they come into ED. And I want to show you how your adult echo skills can be used in the collapsed neonate in ED to actually really help deliver an anaesthetic, speak to your retrieval services, and resuscitate them. So this really is a flavour in the first session, and I'm hoping the second session we can get a lot more nitty-gritty, looking at lots of echo images and look at some really interesting paediatric echo findings. But with that said, I'm going to make some attempt to share my screen using this newfound software that I've discovered this evening. And I'm hoping in a second that you can see the slides. Can someone just confirm that?
That looks good, thank you.
Perfect. Okay, so let's get going. So I've already mentioned this. I'm going to go through how we develop paediatric POCUS, look at the children's acute ultrasound or CACTUS course and what CACTUS is, which is sort of Fusic and famous type equivalents. Look at how POCUS imaging differs in children, and look at where there's some crossover and how you can use your crossover to be involved with CACTUS if that's something that you so wish. And then we'll have a little intro to some paediatric cases, but really the next session will be much more, it'll all be case-based discussion. Please feel free to chip in. So let's go through how paediatric POCUS developed. Well, this is a PubMed search looking at adult publications on POCUS by year. And the first POCUS publication in adults, you may or may not be aware, came out in sort of 1963. And there was either nothing or very little till about 2013 when it suddenly took off. And 2013 onwards, you can see almost an exponential growth in publications related to how POCUS of a variety of body systems can be used in adult practice. This isn't just critical care, this is adult medicine, including rheumatology, acute medicine, everything else. But you can certainly see that in 2024, there was nearly 680 publications on POCUS in that year alone related to adult medicine. Decent amount. And I don't need to tell you this, but you've got this integrated within your curriculum. You've got options for special study years. You've got access to Through Sick and Famous, and you've got your level 1 emergency medicine ultrasound. And subspecialties like respiratory medicine have to be able to demonstrate specific skills like ultrasound guided chest drain insertion. So within the world of adult medicine, you guys were leaps and bounds ahead of where we were in children. So what about the children? Because one of the things we find in paediatric practice is that there's no mass numbers in paediatric practice. So you have hundreds of adults coming at hospital, there's not hundreds of children. You have the interest of exec boards because it's a huge part of your work, and paediatrics often gets a bit left behind. So what about the children? What about the evidence? Well, first of all, we have to break the scale down, because the first paediatric POCUS publication wasn't until 2015. And despite the best efforts of people around the world, our POCUS publications and evidence-based practice behind POCUS in children has really lagged what you guys have been doing in adult practice. For many reasons. Partly it's the fact that we've not had the infrastructure to get people scanning to be able to do the research. So paediatrics has really lagged behind, both in terms of research, in terms of integration in curriculum, and in terms of use in general clinical practice. There's been a huge amount of frustration about this, because one of the things that is really an inhibitory problem with POCUS in paediatrics is almost no general paediatric wards have access to an ultrasound machine. And how can you create a POCUS program when you haven't even got a machine to start with? And in the current climate of funding, asking for a machine is not cheap and easy. So we did a bit of work which might surprise or shock you if you're in adult practice, looking at what are paediatric critical care units doing. So we found that every paediatric critical care unit has an ultrasound machine, and almost no paediatric units general paediatric units had an ultrasound machine. Even paediatric emergency departments that were standalone didn't have a machine. So we focused on paediatric critical care as a starting point. And the top graph asked service leads to audit and report back how often ultrasound was used to carry out various procedures. And you can, so black was always, the dark grey was often, the light grey was half the time. And what you can see is that, thankfully, P is PICU, T is transport teams. 100% of teams are using ultrasound for internal jugular CVC. Great. Heading on for 85% for femoral central lines. So clear lines take a big drop off. Arterial lines, no transport service is always using it for arterial lines. And you can just see how there's really a massive drop off of how this is used. What's really interesting is the graph below looked at how often do you use point of care ultrasound to make a diagnosis in paediatric critical care. And even something like a pleural effusion, only 40% of the time were units always using ultrasound to diagnose a pleural effusion. I mean, that's pretty shocking, really, in adult practice where, you were almost always using ultrasound to diagnose pleural effusions. And so even pericardial effusions were only 38% of the time were people using POCUS to diagnose it. So what we've basically found from this is only critical care units in paediatrics had an ultrasound machine. Even if they had it, they were rarely using it for a diagnostic tool. it was mostly for intervention, and the intervention tool was really central line insertion. So we had work to do. And one of the barriers that came out in this was that people kept saying, well, there's no data. There's no data to support its use. There's no evidence behind it. And so we ended up in this circle of, how do we get evidence if people can't scan? But how can we get people to learn to scan if they don't believe there's a point because there's no evidence? So we spent quite a long time doing meta-analysis and data collection and reviews of papers and small audits and projects, and put together this paper that was published, really to say respiratory ultrasound can be used in children. And we found, as you'd expect, no difference in adults. Lung ultrasound was a lot more sensitive and a lot more specific than the chest x-ray, exactly like you guys have data for in adult practice. There was very little difference in the adult data to the pediatric data that existed at the time. We then went through and described in this paper all of the key signs that you can see in respiratory ultrasound in children. And if you look down that column, none of those will be a surprise to you if you do lung ultrasound or be anything different. And we highlighted a few differences, which I'll pick up on when we get to that section. But basically, this said this could have been an adult paper. So we now had something to say, look, respiratory ultrasound can be used in children. We did a subgroup specifically looking at ARDS and what we call PARDS, or Paediatric Acute Respiratory Distress Syndrome. And what's really interesting about PARDS is in the diagnostic criteria for pediatric ARDS, it says imaging changes. It does not specify what that imaging modality is. So whereas adult definitions have chest x-ray CT changes, actually pediatrics didn't specify what the imaging modality was, which allowed us to say, let us describe how you can diagnose pediatric ARDS using lung ultrasound. And we described how you can use it to diagnose and presented some cases. We described how you can use it to identify complications. So, you know, developing the pneumothorax, developing a VAP on top of the ARDS when they're being ventilated, and so on. And then looking at monitoring progression, so lung recruitment and fluid balance assessments, etc. So now we had a reasonable amount of respiratory data that allowed us to go to critical care units and say, look, let us concentrate on lung ultrasounds because we have data, it can be helpful and useful. And we did that. And this is a study we did, which again, could easily have been an adult study. We looked at 100 children that presented to a our pediatric tertiary hospital at Southampton. And any child that got a chest x-ray got a lung ultrasound by one of the a core group of the pediatric team that we had trained up and put through FUSIC lung. So not a CACTUS lung at this point, FUSIC lung. We put them through FUSIC lung, that's what existed. And we got them lung ultrasound savvy. And as soon as we had a team that could provide this service, any child that came in that got a chest x-ray got a lung ultrasound at the same time. And this gives you the breakdown of the data. But the headline message here was if the child had a normal lung ultrasound scan, they had a normal chest x-ray report. Okay. In other words, for the ED physicians, if a child came in and you ultrasounded their chest and their chest was normal, there was no point in doing a chest x-ray because it was going to be normal as well. It was a great screening tool. As you can imagine, most of the children did have something on the scan because pediatricians don't x-ray children very often. So they were already selecting a group that were likely to have a disease. And what they found is that if you had an abnormal lung ultrasound, you had an abnormal chest x-ray, and that actually 90% of the cases it was the same disease. So pleural effusion, pneumothorax, consolidation. Interestingly, the ultrasound, as you'd expect, being more sensitive, found additional pathologies that the chest x-ray had missed. But basically, we now had a really solid mass of respiratory data, which led us to what you're all here for. What about echo? or the cardiac side of things. And you're probably very familiar with the RUSH protocol, the rapid ultrasound and shock protocol, or potentially if you ED, the extended fast scans and other protocols that take you through the shocked adult to help develop an assessment. Well, we proposed and piloted this in this paper where we talk about using point of care ultrasound in the management of pediatric shock. So when a shocked 6-month-old comes in, why can't you use ultrasound to determine the cause of the shock? And actually, we demonstrated that this sort of slightly modified RUSH protocol really is really valid. It works. And you do exactly what you do in adults. You look at the lungs, you look at the heart, you look at the IVC if you believe in that, and you look at the abdomen. But there is some subtle differences here. So when you are an infant and neonate, you can lose more than half of your circulating volume around the skull vault, whether that is from being a shaken baby and subdural bleeds, whether that is from trauma, or you can have congenital venous abnormalities, sort of AVMs, like vein of Galen, which is a congenital venous abnormality where you get high output heart failure from high venous flow. In the abdomen, we can get hepatic hemangiomas that give you high output heart failures that can present with shock. So there was a few additional congenital things that we added in, but actually this was pretty much the same as the RUSH protocol, accepting that the pathologies might be a bit different. So now we were starting to say, okay, it's time to bring in the cardiac component to this. And after lots of petitioning and debates and presenting the data, Bogdana Zoyka, who's a paediatric intensivist at King's College, and myself were able to get a chapter in the APLS book on the use of point of care ultrasound in paediatric resuscitation. And it's an appendix, but you have to start somewhere. But we were also able to go through the journal, go through the textbook and add in where POCUS could be helpful. So when it comes to assessment of a pneumothorax in the B section, it now says, can use POCUS if accredited. So we were able, you know, if you got pericardial effusion, it says can use POCUS if accredited. So we've now got APLS on board in saying point of care ultrasound has a role in pediatric emergency scenarios. And that was a really big deal in getting buy-in from people. So as we were building up an evidence base, it was really apparent that we had to train people. And part of me originally said, you've got a great infrastructure, you've got a FUSIC heart, you've got a FUSIC lung, let's just put the paediatricians through the same system. That was met with multiple problems. The first problem is there is actually some differences in pathology. So, for example, if you put an echo probe on in an adult that was breathless and you saw distended RV, you would immediately think PE. If we put an echo probe on and see a distended RV, we immediately think pulmonary hypertension. So whilst the findings might be the same, the etiology of those findings varies. So there was some differences. And, you know, we've talked already about some of the high output heart failures that can occur, and you can scan the heads as part of shock. So there was definitely problems. The second issue is there was a psychological thing of children are different and we should therefore have our own pathway, which if you've heard me talk about resuscitation of children ever, you'll hear me say frequently the biggest problem with pediatric resuscitation is not the wrong action, it is inaction. And people are so afraid of children being different that they do not do anything in fear that they will do the wrong thing, and therefore the child deteriorates. And actually, if you defaulted back to your basic critical care medicine, there's not that many differences between infants and children and adults, really. And so doing something is better than nothing. And so we had the same argument of ultrasound, but ultimately to win this battle, we were going to have to create something that was pediatric specific. And we created the children's acute ultrasound. And we did that by looking at all the things that you lot have all done for years. Looked at your adult courses. We looked at what FAMOUS and CUSIC was, if you remember. That's when we showed my age, the original adult ultrasound courses. We looked at what FUSIC were doing. We looked at what FAMOUS was doing. We went internationally to look at other courses that children were running, although there was very few. We then ran a modified Delphi method around some of the adult POCUS gurus to what should be included, and we had a core group of paediatric intensivists that do a lot of POCUS and looked at what should be included. And then we ran the first course, got the candidate feedback, adjusted it, ran the course, got the candidate feedback, and repeated the bottom 2 points a few times until we ended up with a course which we took to some external agencies. So we took to the Paediatric Critical Care Society and the Intensive Care Society, and they did a curriculum review, reviewed it and endorsed it. We took it to the Royal College of Paediatrics and Child Health, who endorsed it. But most importantly, ALSG, that run all of the advanced life support courses, sent some educators to review the curriculum and review the course and provide quite extensive feedback on how to make the course better, how to make the governance more robust, and then fed back to the 3 main stakeholders, who then agreed to endorse CACTUS as the mainstay of POCUS training. All of this took a few years because COVID happened in the middle of it, which was a bit of a nuisance. But this was really important to get external buy-in, to get stakeholder approval. And this was what the course timetable looked like. So slightly different to how FUSIC and works, in that FUSIC, you'll have different modules, you'll have cardiac on its own, etc. FUSIC heart is a full day. But we were starting off with a very different aim. Most paediatricians had never held an ultrasound probe before because they didn't do ultrasound guided lines. So we were starting with the aim of creating a very basic introduction to the body systems that we would then build on. So they start off doing basic physics, probe selection, how the machine works, and then they break out and get to play with the machines. We then do a lung ultrasound lecture, which covers the key pathologies of pneumothorax, pleural effusion, consolidation, and interstitial syndrome. And then they break out and do ultrasound of their lungs. We then do the same for cardiac. With cardiac, what's really important for you to understand is that this is not FUSIC heart, and it's definitely not FUSIC HD, and it's definitely not echocardiography level, BSc, etc. This is there a preload problem? Is there a contractility problem? Is there something compressing the heart? So the requirements are really very basic for this, and we'll come back to this when we talk about paediatric cardiac ultrasound in a minute. We then do some hands-on. We then do some abdominal ultrasounds, which is very basic again. We then do vascular ultrasounds and some practical, and then run through some cases. So this is really a very introductory day for people. We published our data last year. We've done a lot more than this now. So at the time of publishing, we'd ran 42 courses. We're now nearing 60 courses that we've ran at about 18 venues across the UK. We've trained now well over 1,000 people. About half of them are resident doctors from sort of ST1 through to 8. But about a quarter are consultants, which is really important because you need the consultant buy-in. And we've also trained a load of other people as well, sort of, physiotherapists for lung recruitment and optimizing non-invasive ventilation for lung, etc. We've trained. We've done some ward nurses that want to learn about bladder assessment and finding other bits and pieces for block catheter scenarios. So we've trained a range of people. And therefore, we had to then follow this up with an accreditation pathway, because we all know doing a course and then walking away from that course does not make you a good scanner. You have to have additional support. And this is where the Intensive Care Society now host CACTUS for us. So the way this works is people enter the CACTUS program by going to one of the study days that I've described. At the end of that study day, you have 2 options. You decide, I'm done. That was really interesting, good CPD, never going to do it again, or I'm just going to go and practice on my own and not have a governance structure. That's fine, we can't control that. But if you want to go and do this properly, you then enroll with ICS, like you would do with FUSIC lung, FUSIC heart. You would roll with CACTUS lung, CACTUS heart, CACTUS abdomen. And when you do that, you get 3 things activated. You get sent a logbook, which describes how many scans you have to have, the range of pathologies you must include. You get allocated to a mentor in your region, which I'll come back to because some of you may want to take part in this. And you get a mentor, and you also get access to e-learning. And on the e-learning platform, there's a lot of MCQs. There is recorded lectures, there is some resources to work through, there's some little videos to watch about different diseases. And when you have completed the e-learning, completed your logbook, and completed the mentorship program, including your triggered assessment, you can submit that evidence to the CACTUS committee, and if it's all fair game, you get accredited. And like FUSIC, you can then go on to be a mentor when you have done, or a trainer, sorry, when you have done a year of scanning and demonstrating ongoing support. And this is live now for lung and heart. You have to do physics within each of those modules. Abdomen is coming online in December. Vascular is coming online, hopefully January. Well, that might be a bit lot later. But we'll have had all the core modules done and released really by the beginning of next year. But there's work going on with future modules. So there's groups of us working on advanced respiratory, looking at diaphragm movements, looking at prediction of extubation failure, look at lung aeration scoring. There's a group of us that are working on advanced cardiac, which will be split into 2 bits. It'll be a bit like FUSIC HD. So the functional and numerical data assessment, but there'll also be a congenital block where looking for congenital heart diseases. And what I'm hoping to do is, if this isn't too boring for you, is to have another session where I've got 10 cases that have presented to district general hospitals of neonates that have collapsed. And I have got the images that have been taken by the ED physician or the ICM trainee that have done adult echo and sent to us to say, I have no idea what I'm looking at, but to show you how it can be helpful and to make you look at those images. And it's definitely advanced stuff, but I want you to have a flavour of what CACTUS is. But advanced cardiac is on its way. There's a neuro block looking at cranial ultrasound scanning, TCDs, optic nerve sheaths. There's advanced abdomen, which includes all the same things. There's a neonatal block, which you guys won't be interested in, but that's looking at umbilical lines and other bits and pieces. And then there's an emergency medicine block looking at nerve blocks, soft tissue injuries, fractures, which there's an EM group working on. So the idea being is CACTUS will be an umbrella term like FUSIC, and people can choose which modules they want to do and work through as and when they wish. So that is where we're at now. We've got 2 of the modules live that are basic level, and we're working on advanced modules. And the reason I wanted to do this session is we have a very limited number of trainers and mentors and supervisors, depending on which module you're working through. And we need your help, because there is almost no difference in almost all of the body systems in scanning adults versus children. So, for example, if you're a lung trainer in adults, you can be a lung trainer in CACTUS automatically, and we've set up with ICS that there is equivalence across that. If you are a CACTUS, if you are a FUSIC heart mentor or supervisor, you can be a CACTUS heart trainer and sign people off, because the CACTUS heart is such a basic level. It is, can you find the left ventricle, comment on its filling status, comment on its contractility, comment on pericardial effusion, comment on pleural effusion. That's it. There is no measurements, there is no valve assessment, there is no structural work. It really is the LV moving? Yes, no. Is it filled? Yes, no. Is there anything compressing it? Yes, no. So I know that in FUSIC heart, you have to have a mentor and a supervisor. For CACTUS heart, you don't have to do that. The same person can sign you off. When it gets to the advanced cardiac, we will be running the same process as FUSIC heart and FUSIC HD. But that's important because we need your help. We struggle with access to mentors, especially in certain regions. So if you are a mentor for adults, you can be a mentor for CACTUS lung, CACTUS heart. But you do have to understand where some of the differences are. And that's where people get a bit nervous. What if they're signing people off for things they don't know that they don't know? So this is a slide I use in a lot of my talks where children are not aliens. Blood flows around the body the same, gas exchange is the same, renal perfusion is the same, and therefore actually you can do this, and you could scan a child in your ED resource tomorrow if you're called down to help and interpret your findings in the same way. But in saying that, there's some technical differences. So the first thing is the size of your patient versus the footprint of the probe. So if you're doing a lung ultrasound, for example, and you put a linear high frequency probe on the chest, on a neonate, just beneath the clavicle might give you the entire anterior chest wall. There is no need to slide around because you can see everything in one probe. You also don't need to use a low frequency probe for lung ultrasound in most children. You'll get it all in one. For neonates doing cardiac, if you've got an adult probe and you put it subcostally, you will see both lungs and the heart in the same view, and you'll do everything in one image. So actually, the size of the patient is different, but it makes it a lot easier for you. Okay. I also promise you, and this goes back to depth of tissues, that you just need to keep an eye on your scales. So if you pick cardiac on a sonocyte as an example, it will default you to sort of 12 to 16 centimeters. In a neonate, that will go right through the chest, into the bed and beneath. So you might just need to drop your scale. You just need to be a bit of aware of the scales in which you're working and alter depth. But the size and the depth works in your favor in that you will get the best images that you can ever see in pediatric POCUS images. As an example, when we have a suspected pediatric or infant coronary event, which, believe it or not, children have MIs, children have strokes, it's just they're a lot rarer than adults, we can actually map out the coronaries on echo. So you can see right down to the branch of the circumflex on the left, you can see right down to the LAD, you can see colour flow down them. We very rarely have to go to cath lab to look at coronaries in infants and children because you can just map them out so beautifully. So if you can find a left ventricle on your COPD hyperinflated ventilated adult patient, I absolutely promise you, you will find your LV in a neonate and infant, and it's not in a different place. So yes, there's differences in size and depth, but they work in your favour. Patient cooperation is a problem. Some children find it highly amusing to have a scan. Some children find it terrifying. I would say in critical care, most of these children won't know about it, so that isn't a problem. But if they are awake, that might be an issue for you. Temperature control is a technical issue. So if you're putting cold jelly onto a small neonate, they will get cold really easily. So you just need to be aware of trying to keep them warm. Your own confidence is really the biggest problem. You believe it's so different that you won't do it. And I've heard people say, I don't scan children. And actually, what I've done is I've asked them to scan, and I've WhatsApped in on our retrieval calls and looked at what they're scanning, and they actually interpret it themselves. It's just that confidence. And there is some difference in how we orientate images, but that is totally independent, do it yourself as you want. You don't have to make that a technical difference. So none of those, in my view, are relevant to you as long as you're aware of the scale and the probe frequency choice. So what about the actual ultrasound sign differences that you see? Well, the first is bone calcification. So in neonates, their bones are not fully calcified, so the ultrasound often transmits right through them, which means on a lung ultrasound, as an example, rather than see rib dropout and black shadow, you might just see circular ribs and still see the pleural line beneath the rib. On echo, that works in your favour, but if you've got a big adult probe and that's all you've got in your machine in ED resource, and you put it on a neonate's apex to look at an apical four-chamber view, then you might be able to see through the ribs potentially. But bone calcification is a bit different, but again, it works in your favour. The next thing is, in the first sort of 24 hours of life, if you're reviewing images from people, neonates have a lot more B lines. And the relevance of that, or the importance of that, is that when neonates are first born, they have got a load of amniotic fluid in their alveoli, and it takes a while for that to clear. So if you put an ultrasound probe on a baby that's 3 hours old, they will have shed loads of B lines, but that'll be normal. It's really after 24 hours, you should go to your normal number of B lines that adults have. In terms of cardiac stuff, your heart rates are faster. So when you put a probe on and a heart rate's 150, you do have to just slightly focus on the LV function a bit more. It's just subtly harder to decide if it's down or not. But you know, the more I look at it, the easier that gets. But that's just something that occasionally catches people out, that they see a tachycardia and wonder what's going on. But remember, they've got a normal tachycardia. If you do start doing measurements, which we still do E to A's, you still do CAPSs, all those things are still the same in pediatrics, the reference ranges are a bit different. So it's very normal in a neonate and young infant for you to describe it as diastolic impairment, but in pediatrics, that is normal diastolic function. When infants and children are first born, they do have stiffer ventricles, therefore they have more abnormal diastology numbers, but they resolve sort of really within the first 6 months of life. An interesting thing, if you're scanning children's abdomens, is if you're doing this in neonates, infants, they have this thing called fetal lobulations. In adults, it looks like polycystic kidney disease. In infants and neonates, that's normal. Now, it's really tricky to know, is that fetal lobulation or is that actually polycystic kidney? That's in the realms of radiology. But if you put the probe on in a neonate and see the kidney looking a bit lobulated, and that is probably normal. You can also scan the brain directly, which is really cool. You know, you can put it on the fontanelle and you can see subdurals, extradurals, intraventricular hemorrhages. You can sometimes see abscesses because there's no skull vault over the anterior fontanelle. But again, that's just not even different. That's just unique to that population. You kind of lose the ability to do that at about 1 year to 18 months. But really, the main difference is the pathologies are different, and we'll go through some of that in the 2 case examples I'm going to talk about and a little bit in the next talk. The big red flag is that this is where people are worried. People are worried about missing congenital defects. And your job is to really set the scene of, you are asking a binary question: is the LV contracting? Yes, no. You're not asking, is there a coarctation of the aorta? Is there TAPVD? Is this Epstein's? You're just saying, is the LV contracting? Yes, no. So just be aware of how you phrase what you have done. Okay, so I encourage people to say, I've done a cardiac point of care ultrasound. That's very different to echocardiography. But this is just showing you some of the differences in neonates, and hopefully you can see my pointer, but you can see how you've got circular ribs because you haven't got calcification, and also you've got more rib spaces in one screen, and you've got a lot of B lines. In a newborn, this would be a completely normal looking image. In a 6-month-old, this would be quite an abnormal looking image. So the age matters. In terms of image orientation, this is a apical 4-chamber view. Now, this really doesn't matter. On the CACTUS courses, we train people to scan the adult echo way and the pediatric echo way. This is the pediatric echo way, where they invert the apical 4-chamber and they invert the subcostal view. The parasternal views are no different to what you're used to looking at. So if the pediatricians are showing you echo images, the parasternal views will be the same, but the apical 4-chamber and the subcostal might be inverted. And the only difference is we have left atria, right atria, left ventricle, right ventricle. And we can get into, it's basically like a physiology picture, and we can get into, is that the right thing to do or not? Does it matter? It doesn't actually make a clinical difference. You can invert this and scan it the same way as adults, it's fine. It's about looking at the LV function. And there's different pathologies. So this is an example of a small infant that was bronchiolitis, was intubated and ventilated in the District General Hospital, and really struggled after intubation, which is quite with hemodynamics, which is quite unusual for a bronchiolitic. So not everything is bronchiolitis in winter. Some very astute adult ICM registrar put the ultrasound probe on and sent us some images. And what you can see is you've got your subcostal view down in the bottom, and that's probably more familiar to you. You've got a distended RV, you've got flattening of the interventricular septum, okay? And you've lost that ventricular interdependence of the 2 ventricles. And if you look at the apical 4-chamber view, which is done in a pediatric orientation, you've got right atrium here, right ventricle here, and you can see the right ventricle is distended. The trabeculations are all opened, and the LV is being compressed. If you saw this in an adult, you would probably go PE. If we see this in a child, we go pulmonary hypertension. And actually on starting nitric oxide, this resolved almost immediately within a few breaths of nitric oxide. So there's different pathologies and different image orientations. But even if you can get this image and ask your local critical care team to look at it, a paediatric critical care team, that is a game changer for us, because this changed how we managed this patient within seconds. So what is the crossover? Well, we're all collaborating together and we are all in the same meetings and we're all discussing the same things. So this means if you are a lung or cardiac mentor, you can be a CACTUS mentor trainer. If you are FUSIC lung and cardiac accredited, you do not need to do the CACTUS course. There is a crossover of accreditation. Okay, we're not trying to make you redo courses and learn things that you already have learned. Right, I'm going to ask you to stop the recording now, and I'm just going to finish off with a couple of cases that presented to District General Hospital emergency departments, and look at how POCUS really changed everything about the case.